We now have Professor TITIYAL who will take us through the methods of alignment of toric intraocular lenses, manual as well as image guided.
Thank you, Dr. Manpreet, for a good initiation into this instruction course. I think important thing is how to assess your patient, which is very, very important. No financial disclosure from this particular presentation. Let me summarize what Dr. Manpreet talked about. So we said when to implant toric IOL. I think regular corneal astigmatism, very important, because if you have irregular astigmatism, toric IOL may not work. Anything more than one diopter in a normal monofocal lens has to be corrected. If you're going for a multifocal IOLs, trifocal IOLs, the new generation monofocal plus or EDOF lenses, even up to 0.75 diopters you may have to correct. The second important issue she discussed was how to determine the magnitude, axis and cylinder in the cornea. The devices measuring total corneal keratometry, that is anterior and posterior curvature, is good. Multiple readings on more than one device has to be taken so that you have a more accuracy. Look into a axis match. Power may be little plus minus, but if axis is matching, that's a good regular cornea. And in terms of devices, if you have OCT-based systems, that will be better. Formula-wise, he told us that take into account posterior corneal astigmatism, any formula which takes into this, surgically induced astigmatism, the anterior chamber depth and effective lens position. Apart from that, there are various nomograms, formulas, online calculators which is going to help you to get a best formula for your patients. Ultimately, we are looking for a customization of each patient based on these initial examination and the investigations. Surgery may be effective. There's nothing different in surgery as we do for our routine cases. The only thing different in the cases with toric IOL is you have to measure the astigmatism axis, that is the steeper axis, mark the axis on the eye by various means, place the intraocular lens in such a way it matches the axis which are marked onto the cornea, or you have automated devices which tells you that where exactly lens has to be positioned. Most often, these toric marks are there in the optic-haptic junction. That gives a clear orientation of your lens. And most importantly, avoiding the misalignment on the table or avoiding the rotation happening in the post-op period. So these are four important things whenever we are doing toric IOL implantation in these cases. What are the various ways to mark the axis onto the cornea and alignment also? So you have manual marking, which many people use, and if you have access to image guided systems, which can be Callisto with the JAIS system or Varion the Alcon system, that provides a very simple orientation during the surgery, and it also takes care of all deviation which can happen, because most often you are measuring these patients sitting position, and when patient lies on an operation table, you can have little bit of intorsion coming in these cases also. The other way is intraop abnormality related analysis, that is halos and aura. If you have access to that, that can also add into your surgical accuracy in these cases also. So what are the various things we're looking for manual marking? You can have a freehand marking, you can use slit lamp markings, and you have a marking devices. People have devised various marking devices which may help you in actually dividing your initial representation of marking these cases also. These are various instruments which can give you access to how to do it. So you have a bubble marker. This bubble gives you orientation. It is parallel to your orientation of where you're going to place it. You can acicot-toric marker, or you have a pendular marker which is going to give you more ideas. So this gives you a marking onto the cornea. You have two sharp edges there. Then you have other markers which are based on a slit lamp also, which gives you actual marking onto the axis of IOL implantation. So you have two types of marking. One is a reference marking. Based on that, you're going to mark the axis of the orientation, or you can directly mark the axis by slit lamp methods in these cases also. This is what we should do early where we didn't have the automated system. because it is not only the 3-9 o'clock which is important, it is 6 o'clock is also important to mark, so that when you put the axis marker, you have perfect orientations. So to have a 6 o'clock marking first, you can use any pendular device to give you a 6 o'clock, then mark a 3 orientation also. These are various studies comparing various marking techniques. In fact, all these marking techniques are equally good if they've been done by an experienced person. So you have to get experience how to mark accurately in these patients and get effective marking onto the corneal or limbal surface also. I think if you look into various marking devices, you are going to compare them. But if you have manual marking and image-guided system, definitely you will have an advantage of image-guided system for more accuracy and better outcome in these cases also. So these are various image-guiding systems which are available with us. I talked about other devices, like you have OTAS, Harkstite's system, you have iTrace system which can give you Varion, Callisto, TrueGuide. These are various devices. If you have, you can acquire them. Definitely going to help you. And Aura, which is also a good incorporation into your system. It is a system which can be put onto the microscope optics, and you can measure the wavefront refraction after you make an aphakic refraction in these patients. That gives a lot of guidelines. I'll show you that also. So these are important 5 steps of surgery. So first, we have to have a better IOL selection. That means material which is better oriented. Haptic designs are very important now. We have realized the designs which are better co-opted with a capsular bag that has a lesser rotation in a post-op period. And the rexus has to be perfect. Place your IOL in such a way where it doesn't rotate. You remove the viscoelastic completely if you are using a viscoelastic for an IOL insertion, and align in a proper way also. Just to show you one represented video which is based on a image-guided system. These are very, very important tips. So this is what incision mark is there. This is important because every time when you are doing a toric IOL surgery, if you are in the same size incision, your SI is going to be universally same. So you're not going to modify them. Whenever you're looking toric IOL implantation, don't shift your incision as per the steeper axis. We are managing the toricity by intraocular lens, not by the incision modification. So always remain with the main side, main incision every time, so that you have a nice calculated SIA, which is quite less if you are 2.2. So this is my axis orientation, and this is a rexus orientation. You can see 2 marks are here. These 2 circles are 5 and 5.2 for me. So I'll be going in between those so that my rexus is around 5 millimeter, which is a very good rexus size. Because it is very important to have a good rexus for an effective lens position subsequently also. The nucleus emulsification is as you do. It should be done in such a way it doesn't compromise your posterior corneal, capsule or anterior corneal endothelium such. After we implant the lens, as I said, it's very important to take out the viscoelastic from underneath the IOL, because there is the possibility you might retain some viscoelastic, and that may be cause for rotation in the post-op period. Then also remove the viscoelastic thoroughly from over the anterior surface also. If you want, you can do a little bit of anterior polishing of the anterior capsule. The oriental lens, these 3 markings are very nice, and always make sure your 3 dots matches these 3 lines also. If I show you in a magnified position, you'll see that these 3 marks are right up to the central area also. This is very important to know that they are actually oriented correctly. Then subsequently you can highlight the wound also. So what we have learned here, you do a good rexus, do a good emulsification, implant a lens in a proper axis. Most importantly, remove the viscoelastic thoroughly from both underneath the lens and over the lens, and place the lens accurately also. So this is what you're going to get outcome in the post-op period. You can do only 1 degree rotation from the axis which I had to implant, and there is a 0 diopter change required in these cases also. Day 1, no rotation required, a good visual acuity outcome in these cases also. Little trick on these open loop haptic lenses. They are very difficult to be rotated, anti-clockwise. They are easy to rotate clockwise. You can't rotate backwards. So if you shift from a little bit if you shift towards the clockwise, then you can't rotate back. You have to rotate entire 180 degrees. So therefore, our advice is to leave the lens little anti-clockwise when you're hydrating the wound, so that lens, even it shifts, you can rotate in a proper position also. You can see here, I am correctly oriented now, matching the center line. I thought I'll do a good hydration here. During the hydration, lens shifted clockwise. You can see at least 7 degrees shift to clockwise. Now I'll have to rotate the lens entirely 180 degrees to come to that area also. So that is a small trick. Leave your lens little anti-clockwise so that you have a chance to rotate if there's a shift happening in these cases also. That makes easy access to these cases also. This is so how manual marking should be done. If you are using a manual marking also, you need to have a 6 o'clock, 3 9 o'clock marking so that this orientation becomes more stable in terms there's no introsal effect. And marking should be very sharp and effective. If you have fuzzy marking, that also will give a little bad orientation also. These sharp markings are very good to avoid post-op, deficiency happening in these cases also. Other area is image guided along with the aura system in these cases. So this is a variant guided surgery being done. I have done the Rexis and subsequently I'll complete the phaco. Once we complete the phaco, fill up the chamber with viscoelastic. Now we'll take the optic reflection. That gives you a new calculation of IOL power as well as axis. Accordingly, choose the lens, implant the lens, and place it according to the axis given by the aura. Hydrate the wound. Again, take a reading. It takes 40 readings immediately and tells you on the table that no rotation required for this patient and what will be the residual cylinder also. So that is a very effective way to manage, especially cases of post-refractive surgery where your astigmatism may be difficult to sometimes measure in a pre-op condition. This is a very good way to look into these cases also. So once you have so many various ways to handle, manual versus automated, this is a study we did to compare, is really the automated system going to give you a difference in terms of outcome? So this comparative study where we looked into a bubble marking technique in a manual and image guided by Jai's Callisto system, we realize if you do an image guided system, it gives you much more closer to the axis of desired, and it is significantly better than a manual way, and your outcomes, visual quality outcomes are also better with these devices also. So there is a definite improvement in the quality of vision, though the final acuity may be similar sometimes, but if you look into contrast, the MTF is better with the image guided systems access. Some of the femtosecond laser devices also are with, you can make a little bit of a nudge into the capsular axis area, and that is orientation of lens. And it seems it matches correctly with the orientation of image guided system also, and it can give you a much more better orientation. To summarize the surgical aspects, I think you can look into manual methods, which I said pendulum may be the best way to mark your axis, reference axis. In these cases, image-guided systems are better in terms of getting better visual quality. And interoperability, if you have, that's going to add into your accuracy, not only in putting lens in the proper axis, also calculating the IOL power on the table. Only thing you need to have an inventory of lenses with you, 2 or 3, so that you have accurate lenses in these cases also. That is how you're going to achieve good results from these patients. Thank you for your kind listening.
Great talk, Dr. TITIYAL. Just one query. The sense that image-guided system, the Callisto, the Varion has come to stay. But intraoperative aberrometry, there was a lot of interest initially, but now somehow interest is waning. People who even have it, not using it much. What's your take on this?
The only thing I think, the difficulty is 2 or 3 things difficulties are there. One is the extra cost to the institution or to the surgery-wise. It is mounted onto a microscope, and sometimes the space, surgical space goes little less in these cases, and it takes a lot of time. Because once you do a surgery, then you have to have an aphakic situation, then it takes a refraction, then calculates the IOL power, then you need to have an inventory of lenses if you have to modify them. But if you look at the results in terms of literature-wise, the outcomes are almost similar. If you compare image-guided versus the aura, the result has not changed much. So that may be one reason that it's not become popular. Other thing is sometimes maintaining the corneal thoracic curvature, intraocular pressure, They're all little bit challenging sometimes, and it is not applicable to all group of patients. Like you can't do it in a pediatric patient where it may be most useful. So these are situations little challenging.